Okay, we'll go ahead and get started. Good afternoon, everyone. Welcome to the Department of Medicine Grand Rounds. My name is Vineet Chopra, and I'm the chair of the Department of Medicine. It's a pleasure for me to welcome you today to a very special Grand Rounds, a named lectureship entitled the Wahlstrom Lectureship. This lectureship honors Matt and Agneta Wahlstrom, who through a very generous gift supported the Wahlstrom Endowed Chair and Lectureship in the Division of Nephrology. The proceeds from this chair are used to support the clinical research within the Division of Nephrology and also a yearly visiting professorship, which honors a leader in the field of nephrology and dialysis. And I'm excited to introduce to you our visiting professor and Wahlstrom lecturer today. Dr. Alp Ikizler is the Catherine McLaughlin Hakim Chair in Vascular Biology. He's Division Director of Nephrology and Hypertension and also Vice Chair for Clinical Research at Vanderbilt University School of Medicine. Dr. Ikizler completed his medical school at Istanbul University School of Medicine. He then completed internship and residency in internal medicine at the Sisli Etfal Hospital in Istanbul and came to Vanderbilt in 1997, where he, like many of us foreign graduates, went through another residency in internal medicine and completed a fellowship in nephrology also at Vanderbilt. Dr. Ikizler rose through the ranks to the rank of full professor in 2008. He became the director of the Division of Nephrology and Hypertension at Vanderbilt in 2018, and most recently in 2021 was named the vice chair for research for the Department of Medicine at Vanderbilt, which, as many of you know, is a top-tier institution for research in our country. Dr. Ikizler's research falls into three main areas: the role of nutrition and metabolism in kidney disease, the interplay between chronic kidney disease, metabolic derangements, and cardiovascular disease, and third, the pathogenesis of acute kidney injury, including the role of biomarkers in acute kidney injury, prognostic tools, and long-term consequences. Dr. Ikizler is a distinguished scientist. He has won numerous awards and recognitions. In 2005, he was inducted into the ACI. In 2019, he was inducted into the Association of American Physicians, or AAP. He's also the recipient of the Joel Kopf Award from the National Kidney Foundation, the Thomas Addis Award from the International Society of Renal Nutrition and Metabolism, and has numerous other awards that are too numerous to count, Dr. Ikizler, so I will not go through all of those details. I want to add he's mentored countless physician scientists, many of whom have gone on to storied careers of themselves, and has remained continuously funded by the NIH and Foundation since 1997. I counted well over 260 papers on his CV, in top-tier journals, including the New England Journal of Medicine, the Journal of the American Society of Nephrology, Kidney International, American Journal of Nephrology, and many others. Dr. Ikizler, it is a treat and honor to have you here. We look forward to hearing your presentation. I'll turn it over to you.
Well, thank you very much, Dr. Chopra, for the very nice introduction. Without taking too much time, I would like to thank everyone really a lot. More than you can think in terms of allowing me to be the visiting professor for the Wahlstrom Lectureship. This lectureship means a lot more than just a visiting professorship, because the institution itself, University of Colorado Denver, has a huge place in the field of nephrology and medicine with giants like Dr. Schreier and Dr. Burl and Dr. Linus, and it's always a pleasure to be here and a unique honor to be able to present in this specific environment. I also would like to mention that I've known the Wahlstrom family, especially Matt's, for a long time, albeit through by name, through many connections, through my mentors and other things that I do within the world of nephrology. And I cannot think of a better place for me to talk about what I do in terms of this Wahlstrom lectureship. So with that, I'm going to go ahead and spend the rest of my time talking about the area that I think is probably relevant to the residents, which I feel medical grand rounds should be targeted to. And it'll be about acute kidney injury. And again, acute kidney injury is a huge area in itself, as you will see in the next couple of slides. But I'll be trying to talk about the diagnostic biomarkers as well as the management of acute kidney injury in terms of the dialytic therapies, which I think falls into the mission of this lectureship. These are my disclosures. And I'll start with a case presentation. Again, I would like to make sure that people understand, as much as it sounds that it's a real case, it is a made-up case. So there's no real specific intent in terms of how I developed it, other than to really help us to talk about the things that I like to mention. A 70-year-old veteran male is admitted to the hospital due to chest pain while gardening. Is found to have an elevated troponin levels and an STEMI. He's scheduled for a cardiac cath. The team looks at the patient. Patient has all well-known comorbidities, as well as a stage 3 kidney disease with a GFR of 38, serum creatinine within the last 3 months, and he's taking his usual diuretics, ARBs, and a statin. His admission creatinine is 2.1, and again, as I will show you in the next couple of slides, that falls into a stage 1 kidney disease, and the team is concerned about a new onset acute kidney injury and the potential risk of contrast-induced nephropathy. Why are we interested in AKIs, and why is this the focus of my talk? AKI is a big problem. It is actually known to occur in about 2 to 7% of all hospitalized patients. And there's multiple studies that have shown that it can go all the way up to 30 to 40% in patients that are in the intensive care unit. And in those who actually require dialysis, that is the stage 3 acute kidney injury, mortality can be up to 50 to 60%. And if you take out everything else and compare patients who have acute kidney injury versus the ones who don't in the same setting, having acute kidney injury actually independently predicts morbidity and mortality. And you can make up this number, but I can tell you it's probably about a 10 billion plus that one can attribute to this acute kidney injury diagnosis in the setting of in hospital. And again, what I will try to do with the scope of this large scope of acute kidney injury, I'm just going to give you a couple of updates. I'm going to talk about epidemiology today, about staging and classification, talk about biomarkers, because I believe there's some area that one can actually learn, not only as a non-nephrologist, but also give some impact in terms of the care of the patients from a nephrology perspective. And I'm going to talk about prevention and dialytic therapies. I will not be talking about the pharmacological management treatment strategies, as well as the post-AKI care in this specific talk. And then, as expected from anyone giving a talk nowadays, I will be touching the COVID-19 and acute kidney injury at the very end with a special touch in terms of the health disparities that we might be really seeing in this patient population. Now, data suggests epidemiologically that acute kidney injury incidence is increasing over the last 10 to 20 years. And this is a study and a subsequent study by the same group, Chi-Shu and his colleagues from UCSF in 2007 and 2012. As one can see in the top figures over the years, community-based incident rates for non-dialysis requiring acute kidney injury, as well as on the right, dialysis requiring acute kidney injury has gone up significantly over the years from between 1996 to 2003. And another subsequent study by Shu, again in 2012, suggests that that's the case. And if you look at it, there's a significant increase in the patients who are older than the age of 65. So there's a big problem that we're dealing with, and there's a lot of AKI cases, more than what we used to do. And I think the question right now, from a big perspective and global perspective, why is this happening? How did we get there? Why do we have so much acute kidney injury that did not exist 2 decades ago? And one can actually take this from a very specific epidemiological perspective and say, hey, how did we define acute kidney injury to begin with back in 1996? And how do we define it today? And what we've seen over the years, especially between 1995 all the way to 2005 or so, that there was a significant discrepancy in terms of how acute kidney injury was defined in the published literature. As you can see in this table with the column that is in red, the definitions could be anywhere from an increase of 2 milligrams per deciliter of creatinine versus all the way to an increase of 20% or a 50% from baseline, or a simple need for dialysis that reflected itself on the very right side with different incidence numbers. As we kidney specialist nephrologists are really interested in terms of categorizing things and making them more complex, we said we need to come up with a criteria for classification and staging of kidney disease. There has been several iterations of this specific process, and one of them is what we call the rifle criteria, or subsequently called as a modified rifle, which stands for risk, injury, failure, loss of kidney function, and end-stage kidney disease. And here what we have is 3 different categories. The top one on the figure here is showing the risk with an increase of 0.3 and then doubling of creatinine, and then subsequently is a failure with an increase of 3 times and then the creatinine over 4. This was subsequently adjusted to say that this criteria must be reached within 48 hours of the initial diagnosis. Now, this went through a number of different iterations, but right now what we're using is something called KDIGO, AKI staging. And this table here sort of simplifies this problem. And again, we always try to make things a little bit complicated. We put the urine output as another staging tool, which is not commonly used in the clinical setting. But if you were to stage AKI, this is what you get: a stage 1, a stage 2, and a stage 3. That actually includes the initiation of renal replacement therapy or a GFR less than 35 mLs per minute. Now, gone through this for 2 decades, what this has led us to, I think that's the most important question. What did we achieve over the years in terms of really taking this really diverse definition of acute kidney injury into a staging process that was maybe simple for some? And here I would like to take some reference to our cardiology colleagues and an article that was actually written by one of my good colleagues, Sas Vaikar from Boston University right now, which really talks about how we really approach things in terms of nosology versus a clinically based approach to defining disease. On the top, you see a definition of acute myocardial infarction or myocardial infarction in the setting of a hospital for a cardiologist perspective. And in the bottom, you see the same approach in terms of a patient with acute kidney injury. Between 1960 and 2000s, what cardiologists did was an epidemiological approach. They created a lot of definitions, as you can see on the top. And the bottom, at that time, we didn't have any specific staging, so everything was based on clinical context. We really took care of patients from a personalized perspective and looked at the patient. We didn't have any thresholds. We didn't call them as stage 1, 2, 3. We just said the patient is acute renal failure, which is not used anymore. But everything was clinically based on how to treat the patient, based on what the problem was to begin with, then subsequently dealing with the issues. And then in 2000, cardiology switched the approach and made it a more focus on terms of clinical context. Whereas in the same time, we took the same opposite approach, not the same, but the opposite approach. And we said, we need to get a more epidemiological approach and see how things are really happening. We need to have staging. We need to make it more aware. People need to be able to say this precise, detailed measures of acute kidney injury. And again, the question is, what did we end up with? This is a quote from an early published document talking about the treatment of acute kidney injury, specifically anuria. And I'm going to read this because it's very informative. The treatment of anuria should be conservative. If circulatory failure is present, appropriate steps should be taken to correct it. Otherwise, therapy is limited to balanced maintenance of the patient until the kidneys have a chance to affect recovery. And I would say this is a very wise statement because this was done by Homer Smith 70 years ago in 1951. This is a phenomenal perception of understanding of acute kidney injury and how to deal with it. And again, what do we do now? 70 years of progress. I'm just going to make a reference. This is a note that I wrote for one of the patients that I saw last week. Optimize hemodynamic and volume status, avoid nephrotoxins until recovery. So we have a little bit of a problem in terms of really making a substantial improvement, although we've made a significant progress in terms of defining acute kidney injury itself. Of course, we have to be fair. For our nephrologists, how do you expect these multiple diverse disease states, multiple causes of acute kidney injury to respond to the same treatment, respond to the same strategy? I mean, this is a very oversimplified way of looking at it. But again, the idea here is that we do not really have a good understanding of what's happening with our patients. We don't know what the injury that really causes the problem. And that's a critical issue. And again, going back to our colleagues, if you really look at the progress in cardiology, for example, as shown in myocardial infarction, they have for a long period of time, they had functional markers, but they also added these injury markers on top of the functional markers so that they were able to make some clinical context or add a clinical context to the problem. And then subsequently, depending on the injury type of injury and the functional marker, they were able to create some therapies. Now, if you go all the way down to nephrology, we had functional markers, which is serum creatinine and urine output, but for years, we lagged in terms of what the injury markers are because we didn't have any specific injury markers that are really relevant to the pathogenesis of the disease. And what we end up with right now is renal bed rest. So how do we deal with this issue? Well, the best way to deal with this issue is to create some or find some markers of kidney disease. Now, kidney injury. Of course, I'd like to make an addition here and disclaimer. Anytime you produce a new biomarker of injury, you need to have a gold standard. And right now, the gold standard we use for assessing the availability or the quality of a biomarker is all based on serum creatinine. And again, serum creatinine itself is a pretty, how would I say, non-reliable or a biomarker that is influenced by many different things. For example, it varies by age, gender, race, muscle mass, metabolism. It is not specific to the disease, or it's not sensitive at all. And again, it overestimates GFR in advanced cases such as in tubular secretion. But despite that, we still use the serum creatinine as the gold standard marker for kidney function, despite its limitations. So right now, the kidney world, or the kidney medicine in the setting of acute kidney injury, needs to find a better functional marker in terms of how to really assess. That put aside, I think there has been some progress in terms of the injury biomarkers. This is a slide that I took one of the reviews by Dr. Bonventre, John Bonventre from Brigham, that sort of oversimplifies to some extent, because there are many more, showing the different kinds of novel injury biomarkers one could use in terms of kidney disease. These actually could be used for chronic kidney disease as well, but for the purposes of this talk, I've highlighted some of them that are really important. And again, significant progress have been done over the last 10 or 20 years in terms of how to really understand the kidney injury in terms of the biomarkers that are being utilized. The one that has been most commonly known is this ANGAL, neutrophil gelatinase associated lipocalin, initially studied in pediatric patients. This was a landmark study almost 17 years ago that showed that if you measure ANGAL levels in the urine in individuals, pediatric patients post-CBP, you will see that the ones who have acute kidney injury, in 20 of those, there's a significant increase in terms of ANGAL. That one can actually put into an AUC curve of almost 100%, 0.98, suggesting that you can really differentiate the ones who are going to get acute kidney injury versus the ones who will not get. And you can have a threshold of a 50 micrograms per liter in terms of 2 hours after the surgery. This really created a lot of excitement within the kidney world, and a lot of people have actually took this to the next step to really understand how can we really generalize this or test it in other settings. We also did some studies, but I just wanted to show you one additional slide that is really important in terms of biomarkers. And again, a biomarker could be used for many different reasons. You know, if you wanted to use a biomarker for diagnosis, for example, ANGAL, if you have a good test that really can tell you whether something's happening, you can be very effective in terms of saying that somebody has kidney function decline or not. And again, ANGAL is a great diagnostic marker in the setting of established acute kidney injury, but it's not the only one. Actually, all of the markers that I've listed here can actually be very effective, can be considered very useful in terms of diagnosing a established kidney disease. But we also know that we can really find that out pretty easily by looking at serum creatinine at the same time. So the utility of these biomarkers as a diagnostic tool is not adding too much to our knowledge. What we're really interested in is, can we predict development of AKI by using these markers? Again, taking on the study done by Mizra and colleagues in 2005, we did a study with collaboration with our pulmonary critical care colleagues, Laura and Whale. We did a large mixed adult ICU study where we collected samples from urine and blood at the time of the admission to the ICU, and then followed the patients over 2 days or so, and to see which ones are actually developing acute kidney injury. And when we took those individuals and measured their urinary ANGAL, what we found is that you can actually have an AUC curve of 0.77, so 77% of the patients being predicted by use of an ANGAL to have AKI or not. And that actually dropped down to 48 hours. For a lot of people, and in the biomarker world, 0.77 of AUC is actually not a bad number. Now, some people have a threshold of 0.8, but again, we will take this as a useful biomarker that one can actually generalize. But of course, what you're really interested in is that, is this really adding anything to our current knowledge? So we went back and did the same analysis using 2 different approaches. One is we took the patients and created a clinical model, nothing additional other than the clinical data that we have in the setting of admission, and then predicted what was going to happen. And we were able to get a AUC curve of 0.81 ROC. And that was actually better than what we had with the ANGAL. And then we said, well, if you were to add NGAL on top of this clinical model, what would be the additional effect so that you can take the patient, predict what's going to happen, and then add an NGAL and say, hey, I can really differentiate or stratify which one is going to get into trouble. And it turned out that addition of NGAL did not make a big difference. So clearly what this says is that in terms of diagnostic purposes, NGAL could be useful, but in terms of early prediction, it may not be as effective as we think, or it's not really adding a substantial value to what we normally do. And again, this might be for various different reasons. I want to tell you that AKI in itself, both clinically as well as the pathogenesis that's happening behind this clinical picture, is very complex, and a lot of things happen over a long period of time. AKI is a very dynamic process, and within that time period, it is really hard to really anticipate what's going to happen, whether a patient is going to have an AKI or whether they have AKI or not. And if you look at this slide that I've taken, which is relatively old but still applicable, that you have the pre-renal state, you have the initiation of the problem, you have the extension of the AKI, and then you have a stabilization, or what we call a maintenance, and then subsequently there's a repair process that's happening. And the question is, when do you take your sample or biomarker at that specific progress or timeline? And interestingly enough, if you were to look at different biomarkers at different time points, and in this case, looking at patients post-cardiopulmonary bypass surgery, each biomarker has its own timeline and kinetics. So if you were to look at the first 2 hours, you will see that 2 of the biomarkers listed here are actually pretty high, but 2 of them are low. Whereas if you were to take these samples 12 hours after the cardiopulmonary bypass, all of these are high. So the timing of this is a little bit of a hit or miss, or you really want to know exactly what you're really looking into and what you're really interested clinically in terms of the use of the biomarker. If the idea is that you want to diagnose someone, that's fine. You can take KIM1, you can take NGAL, and you can check it, and then if it's really established, it'll give you an idea. But in terms of who's going to get into trouble, it gets to be a little bit more complicated. And again, the other thing that one really needs to take into account, and that's more of a generalized statement in terms of biomarkers. Creating a biomarker is a great opportunity to really make a big impact, but it requires a lot of time and effort. And there are multiple phases of or stages of biomarker creation, including the proof of concept, prospective validation, the incremental value, which I've shown you previously in our study, its clinical utility, and then its effect in terms of clinical outcomes, and then finally its cost effectiveness. Are you really getting your money worth in terms of using this in a much generalized process? And again, all of these require different studies, one after the other, or done concurrently at the same time. And to be able to take that specific biomarker and apply it to an AKI takes a little bit of time. I want to show you this because I think within the world of AKI, we've made significant improvement and progress, but we still have a lot of work to do. And I think this is one of those things that happen in the biomarker world, that you do run out of steam because you don't really get to where you want to get to quickly. And again, there are also different ways of biomarker utilization, especially in the acute kidney disease setting. You know, if you take this concept of you have a well-established marker such as creatinine, and then you have a biomarker, you can actually combine the two together. And you can have a biomarker and positive and negative, and creatinine positive and negative states. And if you were to look at this in a different way, you know, if you have both creatinine increase and a plus positive biomarker, you can actually say, hey, you know what? I definitely know that there's somebody that has the AKI. Now, what I can do is with established disease, I may be able to look at the related outcomes because I'm pretty sure that this patient has AKI. If both are negative, then you can do the opposite. And again, you can find the patients that are at decreased risk for related outcomes. So there's a utility of using both. In terms of the negative side, if you have a biomarker negative or a creatinine positive one, then you're really probably dealing with these false positive in terms of serum creatinine, because you think the biomarker injury is reflection is of a disease process or some injury that's going on, whereas the creatinine is more of a hemodynamic change, such as volume depletion or impact of a medication or increased production of creatinine, such as rhabdomyolysis. So this could be another opportunity to really use your biomarker. Again, the same is applicable to a serum creatinine and a biomarker positive, where you have this false negative, where patients could be at increased risk for future AKI. I just wanted to show you one slide that this is something that people have done, which I found very promising. So this is a study using a new test called NEPRO test. I'm not going to read the whole thing. And here what they have done is that they've taken 719 patients and they measured both the creatinine as well as the NEPRO check. And then they classified those patients according to the way that I explained. And when you look at the individuals that are both biomarker and injury marker creatinine negative versus the ones that are both positive, there's a substantial difference, as you will see in this slide over here, in terms of estimated survival. Here, you can really stratify the patients as being a high risk and a very low risk. Of course, what we're really interested in the middle part, but I think this is a really important advancement in terms of biomarker research. So let's wrap up this part in terms of biomarker development and utilization. I think there's still additional steps that we need to use in terms of avoiding the lost in translation concept. We need to have a little bit more understanding of the kinetics and pattern of expression in different settings. I think we need to get some tissue origin, which is really something that I will refer to subsequently, because without understanding what's happening in the tissue, it is very hard for us to really come up with an injury marker. And then we need to go beyond creatinine, and then we need to take leverage of larger cohorts. Let's go on with the case and go back to the initial question. They're concerned about this patient, whether this patient is going to have an additional worsening of acute kidney injury with the potential effect of contrast or not. Here, what we're really trying to do is prevent any additional injury. And this is a question that is very hard to answer in the setting of AKI, because the studies that one can utilize in terms of efficacy and good studies requires a lot of effort. AKI is a complex disease, and recruitment of patients requires a lot of effort. And I'm just going to give you an example here. Like if you were to take this issue like this contrast-induced nephropathy with low prevalence, and then you take a medication that has moderate efficacy, you really need a huge sample size to show an effect. Like in a study designed to reduce mortality from 55% to 45% with a 10% absolute difference, with the usual criteria, that would require about 1,100 patients in each arm. Whereas if you were to do multiple arms, that's really getting to 3,000-4,000 patients in the ICU setting or in the hospital setting, which is not an easy task to do. So for that reason, we really struggled over the years to be able to do the right studies. But that should not deter us, because there are studies that have done this or have overcome this specific barrier. And one of them is this study that I'm going to show you here, which is looking at the contrast-induced nephropathy. In this study, Paul Polewski from Pittsburgh and Steve Weisberg from Pittsburgh and colleagues have done a VA and NIH study combined of patients, a total of about 4,993 patients that were assigned to 4 different arms, looking at the effects of sodium bicarbonate or acetylcysteine in terms of prevention of contrast-induced nephropathy. This was a very large undertaking, took a long time, extremely well designed and carried out, and really showed us very important results. And again, I don't want to be nihilistic here or negative here. Unfortunately, this study, as we see in the kidney setting, was negative in general. If you look at the p-values in terms of comparison of bicarbonate to normal saline, all the p-values are non-significant, and then comparing acetylcysteine to placebo are also not significant. And again, a lot of people might take this as a very disappointing result. I sort of take this in a different way. I think this PRESERVE trial have taught us a lot of information, despite its null results. First of all, it was the largest sample size of 1,177 patients initially consented and randomized. Showed us that you can actually do these studies for patients with acute kidney injury. It took a high-risk group population, and then it showed that we don't really have to worry about sodium bicarbonate or acetylcysteine over placebo or sodium chloride. It's just meant that you don't have to really use those, and it's okay to know that. It gives a lot of opportunity in terms of resource utilization. It also showed us that contrast-induced nephropathy is a low incidence. There was a 4% composite outcome. So there may be less of a concern in terms of this issue, in terms of our care of our patients, and maybe allow us to really be more aggressive in terms of utilizing these contrast-related procedures in our patients that require it. And finally, it showed us that the fluid replacement is the best strategy, and that takes us to the next thing. Of course, if the fluid replacement is what we need to do for this patient, which fluid should we give? Should we give normal saline or a more balanced fluid? because the data over the last 10, 20 years have shown us that even small bits here and there, cohort studies, observational studies, that there may be a difference in terms of a saline administration versus use of a more balanced fluids such as plasma-light or others. And this led us to really another study, which I think is a really important step in terms of how we can really do research. And I'm going to make this an important point because this is something I take pride. This is a study that was done at Vanderbilt utilizing a cluster randomized multiple crossover design for a pragmatic trial called SMART study. In this study that was started in 2015, multiple different ICU intensive care units were randomized to, on a monthly basis, to a balanced solution versus sodium chloride over a period of 3 years. The bottom line is that we were able to get almost 30,000 patients into the study over a period of 3 years with as little resources as you would use, but in a very efficient infrastructure that is allowing this to happen. And again, this is one of the future approaches for pragmatic trials. So I really am very honored and I'm proud in this specific trial and my colleagues in the ICU who have done it. And just to show you that when you really do this complex, but pretty well designed study, you can really achieve what you're really interested in. And this is showing the proof of concept in a sense that the plasma volumes values in terms of chloride and bicarbonate in the two arms over the 6 days of the study. So if you look at the chloride concentrations, the ones who received the saline had a much higher concentration versus the balanced ones, which is the expected and one of the reasons why we believe this issue is a problem. And then if you look at the bicarbonate, the balanced solutions had a significant improvement, higher value compared to the saline over the 2 to 6 days of the study. And again, this is a very promising way of showing that you can really separate the groups in such a large population in a pragmatic way. And this study outcomes is shown here. And what you see here is that if you were to look at the comparison of balanced crystalloids versus the saline, there was about a 1% improvement in patients' overall outcome. And this was considered to be, you can take it from two different ways. One, you say, well, a 1% risk difference is not much at all. It was significant because it had a huge patient population that helped us to say this is a statistically significant issue. But if you were to think that there are millions of patients that are actually being treated with this specific therapy, a change from saline to appropriately to balanced crystalloids could actually make a significant impact in the larger scope, even a 1% change. So this was a very important study that one can actually take as an example for future studies in the setting of acute kidney injury. Now, I do have to say, everything comes with a little bit of a limitation or some disclaimer. So this is a study that by design is unblinded. Everybody knew what they were doing, including the treating clinicians. And a lot of outcomes such as renal replacement therapy was determined by the treating clinicians. The data was censored at discharge, so we do not know what would happen to the patients afterwards. And then this was a single-center trial and needs to be repeated elsewhere. And I'm showing you this because there was another article that just got published, March issue of New England Journal of Medicine, looking at this from a more conventional randomized, double-blind randomized controlled trial where they had 5,000 patients that are randomized to balanced multi-electrolyte solution versus saline. And the results of that study showed no difference at all. Now, I don't know which one to say this is better or worse, which one is more reliable or not. And you can really make a lot of comments in terms of pluses and minuses of both studies and the way that you can really generalize and make your clinical decisions. But it tells you that nothing is clear-cut in the setting of AKI or a clinical illness. And you really have to use the data and personalize to the individual that you're trying to treat. And again, let's go back to the patient in the last part, which is the management. So the cardiac patient gets cardiac cath, and it shows extensive atherosclerotic cardiovascular disease. And then the patient is referred to CT surgery for CABG. The patient goes through CABG, and the post-day 6, everything is stable. Patient has acute bleed, required multiple blood transfusions, and nephrologist consulted for evaluation for need for dialysis for fluid overload. The patient's on exam is stable, 2 liters of urine output, but the input is significantly higher than the output. Serum creatinine is 2.8, so it's pretty much doubled from the original serum creatinine, but there's a stage 2 AKI here. The electrolytes and everything else is within normal. Here, what you're really interested in is, do you have a drug to really give to these people to treat the developing acute kidney injury? And again, being very careful here with the caveats that I've told you before in terms of really trying to do treatment studies in the setting of acute kidney injury. A number of different strategies that I've listed here actually did not turn out to be positive or effective in the setting of acute kidney injury. And again, that might be because of the complexity of the disease. And there are many other pharmacological approaches that are being tested. And I can't think of any other place other than this institution and this nephrology division, which I'm showing a couple of examples here, who's doing great work in terms of understanding of the pathophysiology of acute kidney injury and trying to be able to find some targets that one can actually test down the road. At this time, I do not have any information for you to share. We have some promising medication that we have in our hands. I also would like to say that there's another large initiative called the Kidney Precision Medicine Project, as shown here on the left side, that is actually trying and actually being successful in terms of obtaining some research biopsies with patients with acute kidney injury, as well as chronic kidney disease, who are going to take those tissue and get it through some integration sites to understand the mechanistic pathways to be able to develop some more precision medicine approach in terms of treatment of acute kidney injury. So that's in the development. It's going to take some time, but I think there's a lot of great initiatives that's going to help us out in terms of being able to come up with some medications. In the meantime, you need to take care of the patient. So you also notice, which I wrote here at the bottom, that on exam, the patient has the left IJ placed. And the ICU fellow shows up and says, well, you know what? We want to treat this patient with CRRT, continuous renal replacement therapy, and says, like, staffing is ready. I know you need to write the orders. I'll just need your approval just to get it written, and then we'll just get dialysis started. And before you say, but, he puts these arguments supporting the CRRT. He says, the patient has some hemodynamic instability. We give a lot of volume. We need to get it out. I cannot cut anything back. And I think this will help with the patient's clearance of these solutes. And again, this patient doesn't have it, but I think CRRT is generally a great therapy compared to intermittent dialysis, not even doing dialysis. So we need to go ahead and do this. Unfortunately, this is one of those instances that we have to deal with at times. And we need to make some recommendations at this stage. And I'd like to go back to this conceptual idea, which Homer Smith wisely put out, that our goal here is that we need to allow dialytic therapies for the balanced maintenance of the patient until the kidneys have a chance to affect recovery. And here, what we really need to do is we need to do no harm. We need to do dialysis because we feel that we need to keep the maintenance, the homeostasis of the patient as best as possible. And in that case, we need to have some data and some guidance in terms of when to start dialysis, what kind of dialysis modality we should use, how much dialysis we should give, and then when to stop. I'm not going to even talk about when to stop, which is a big question in itself, which we're studying in our institution as well as other things. But I'm going to give you a couple of examples of some ideas when to start, which modality to use, and how much. And again, when we do that, it is really critical for all of us to understand that we have a rationale of why we're dialyzing someone. And again, for the residents and students who are following this talk, I'd like to say that the reasons to dialyze, again, is to provide an opportunity for the kidneys to recover and then treat and avoid complications so that you can make the patient to get to that point, well, they'll recover some of their kidney function. And the reasons acutely that we dialyze people include some solute problems such as electrolyte disturbances. Again, as this in this case, a fluid management issue. Or one can say, hey, I would like to increase outcomes over the time period. I'd like to improve the organ failure. I'd like to improve the renal recovery. And then I'd like to make sure that the patients who recover from AKI don't have chronic kidney disease. And again, just to simplify things, we nephrologists try to make things complicated, but dialysis is not a complex procedure. It's actually pretty straightforward. When we say CRRT, we talk about continuous infiltration. We have the dialysis machine, we have the dialysis and everything. But bottom line is, what you're doing is, you're taking the blood, running through the filter, by diffusion, getting rid of the toxins, and then with the dialysate on the other side of the filter, or some additional fluid into the bloodstream, you're actually removing some of the fluids that is extra through some physiological principles. In general, there's nothing complicated about this. It's a pretty straightforward concept if you really pay attention to it. And again, if you were to look at these nomenclature, which seems complicated, it's not really complicated. It is all within explained within the terminology. If you do a continuous ultrafiltration, that means that you're trying to get rid of as much fluid as possible with very little solute clearance. You're not really interested in urea, creatinine, or whatever, but you really want to get rid of the fluid. And in this case, that might be the case for that patient that I explained to you. If you talk about hemofiltration, what you're doing is you're not running any dialysate through that dialyzer, so you don't have any what we call a diffusive transport that's based on concentration difference. But do a convective solute removal, that is, as the water, plasma water is being removed, it takes along all these other toxins along with itself, which is less effective. So you can have all these different things, but in theory, you're not really too complicated in this sense. And both of them, both CRRT and hemodialysis, actually do the same thing, can accomplish both goals at the same time. So in terms of CRRT versus intermittent hemodialysis, you're all focused and obsessed about mortality. I will tell you this. Study after study after study have shown, randomized trials, small or large, that there's no mortality difference between intermittent hemodialysis versus a continuous therapy, whether it be continuous intravenous hemodiafiltration, hemofiltration, scuff, whatever. I think that needs to be kept in mind that when we do these therapies, differences, we do not do it because we want patients to live longer based on a randomized clinical trial. What we want to do is we want to be as individual and potentially responsive to the patient's needs as much as possible. This is a guideline that was published about 10 years ago. What it says is that we do not want to put any patient on renal replacement therapy as shown as red font here. No renal replacement therapy is ideal for patients with AKI, but you got to do what you got to do. And if you do it, please individualize it and then look at the patients as they change dynamically, hemodynamically, or other things, and then tailor the renal replacement therapy based on that, with the caveat that you have to use your available expertise and resources. What about when to start people? Nephrologists have a tendency to start people early because that is something that we can do. That is something we have an expertise in and we can do well. So in cases, we may be just saying, hey, the BUN is X, so I'm going to start the patient on dialysis, or BUN is Y, I'm going to not start the patient. But in reality, what we know is that if you start people earlier than your usual clinical criteria, there's no benefit out of this as well. There's been published like 4 or 5 studies now. The most recent one, the START AKI trial that was published in the New England Journal of Medicine 2 years ago, that clearly suggests that a protocolized initiation of dialysis based on some numbers does not really change the outcome in terms of mortality, the length of stay, or any other things, or recovery of kidney function down the road. So what this comes back is the same concept of personalization and looking at the patient's need and then putting them on therapy. What about the dialysis intensity? Again, we do dialysis well, so we'd like to do as much dialysis as possible. And again, thanks to Dr. Palevsky and colleagues, through an excellent study called the VA NIH Acute Renal Failure Trial Network Study, ATN study, that subsequently was actually validated by a study from New Zealand and Australia called Renal Study. The intensive therapy, that is like everyday dialysis or more fluid running through the dialysis machine to remove more toxins, has no impact in terms of overall probability of death or length of stay or recovery of renal function. And again, what we really want to do is we want to provide as much dialysis as the patient needs, but a lot of dialysis is not going to make a big difference in this setting. And then I'd like to finish up with this concept of health disparities and how really acute kidney injury could be a model for all of this concept. An interesting finding for many studies is that unlike chronic kidney disease, where we have race is a huge risk factor for progression, both incident and progression of kidney disease, race is not a risk factor for acute kidney injury. This is a study by Morgan Grams from Johns Hopkins looking at a meta-analysis of almost 2 million individuals from 5 to 10 different studies that have looked at the multiple different risk factors for acute kidney injury. And it turns out that there's not a substantial difference of being white versus an African American in terms of if someone is going to have acute kidney injury or not. So we really don't put race as a big factor in this specific setting. Now, that has changed over the last 2 years because what we know is that in the patients with COVID-19, especially in the very early days. First, we know that acute kidney injury was very common, and we also figured out that Black race was a big independent risk factor for developing acute kidney injury. So there was something different in the specific COVID-19 that really put patients at risk with a Black race to be in the more risky position. This is a paper that was published in 2020 reporting the early findings, the early wave that happened in New York and Northwell hospitals. And you can see that Black race comes as a very noticeable independent risk factor, along with many other things in terms of having AKI. This was actually validated by another study subsequently looking at the US veterans with COVID-19, showing the same thing about 5,200 veterans. Black race was a very important predictor of an AKI. Again, that really goes against our usual knowledge. And it's really important for us to understand this. And there's been a very interesting review article that was published very recently in a journal not that many of us read, but really shows that, takes the information that gender and ethnic disparities with those predisposed COVID-19 patients with acute kidney injury, and they had some suggestions or sort of proposals in terms of why this is happening. I want to say that this is an area that's really worthwhile to study, especially in the fact that similar things might happen down the road. I would say this is a really intriguing finding. I would like to show you one last slide in terms of data that is actually taking this specific high-risk genotype of APL1, which is a risk factor for chronic kidney disease in African Americans, to see if that really relates to COVID-19. This is a study with my good colleagues, Dr. Adriana Hong and Eddie Su, looking at the APL1 risk variants, acute kidney injury and death, and participants with African ancestry who were hospitalized in COVID-19, taking advantage of the Million Veteran Program, which is a large genetic program within the VA system. What they've done is they took about 990 participants who have African American ancestry, and then looked at their different stages of kidney disease, and then grouped them according to their low risk APOL1 versus a high risk APOL1. Although it's not substantially different, but you can still see that there's a significant difference in terms of risk of AKI with different stages, almost every stage with having the high risk APOL1 versus the ones with low risk APOL1. Again, providing us a new understanding and now opportunity to really study these patients in different settings of acute kidney injury. So just to wrap up, what I tried to tell you today in a short period of time is that acute kidney injury is common, especially in critically ill patients. The pharmacological therapies are not so effective, but there's potential down the road. And most ICU patients with severe AKI will be exposed to at least a day of dialysis modality. In general, take-home message, it is okay to favor CRRT in patients who are unstable, who do not require a major emergent clearance of toxins or electrolyte abnormalities. But again, the idea here is that either one would work if you do it the right way, depending on the patient's clinical scenario. We have a more conservative approach in terms of kidney replacement therapy in the setting of acute kidney injury. The criteria that we've developed for 20 years is not useful for the initiation of dialysis. And again, I am not underemphasizing the importance of the staging issue, but we're in a position where we really need to go to the clinical context and combine these staging and classification with the use of biomarkers to be able to have a better outcome. We do not know how to manage the volume, and we do not know how to provide renal replacement therapy to the recovering patient with AKI. And again, this is a gap that also provides a lot of opportunity for future research. And then finally, the long-term outcomes of AKI, which is a very important area of study, is not covered adequately, but there are a lot of studies that are coming up on that aspect as well. With that, I will thank you so much, and I appreciate your invitation, and I will be more than happy to answer some questions and take some comments. Thank you.
Dr. Ikizler, thank you. That was great. I especially liked how you started with the case and walked us through the evidence and went back to the case to apply it. I think that was very unique and powerful. We have a lot of questions, so let me start maybe with some basic ones for epi and epidemiology. Okay, the first question is the incidence of AKI truly increasing over time, or is this about better diagnoses, a change in comorbidities? changes in definitions, or all of the above? What's driving this
I
upward
will
trend?
be very political and say all of the above. That's usually the answer in all these multiple choice questions. All of the above is way to go. I think they're all contributing. The idea here is to have to balance the real incidence and what's really important to do. Just because we have a lot of AKI does not necessarily mean you need to do a lot. Again, I don't want to sort of underemphasize the importance of AKI incidence, but we need to be a little bit more selective in terms of who's high risk and who's not high risk. And I think that's where the biomarker issue comes into play, where we can really stratify people. There will be a lot of people with AKI. I can give you a lot of examples of different AKI that are happening in a college campus, which I'm not going to go into detail, but we're not going to pay attention to that. Is that right? I mean, you give the floats, everything will be fine. Who is really at risk? Yes, it is increasing for all of the reasons you mentioned. Our ICU docs are doing a phenomenal job. I mean, the way they treat patients now allows those patients to live longer and be more exposed to risk. So all of the above.
That's great. Speaking of biomarkers, could you expand on the utility of cystatin C over creatinine in the diagnosis of AKI? Do you think cystatin C will increase in use and creatinine will fall by the wayside, or where are we with that?
I would say probably not a good idea to add cystatin C to the GFR equation. So AKI, again, needs to be totally separated out from CKD. The basic principle of estimating GFR requires that it is a stable function, that people are stable, that your kidney function is stable, your metabolism is stable. AKI does not reflect that. So the use of these equations, cystatin or creatinine, to reflect what the GFR is irrelevant. You cannot really use them adequately, and it doesn't really make sense. What we really can, much easier is like if a creatinine doubles from one day to another, I can tell you GFR is 0. I don't need cystatin, I don't need anything. The kidneys are not excreting anything. I think that's where we really fall into a big problem. Statin C is a big tool for chronic kidney disease and patients who have a stable metabolic state.
So then help us understand this. How do we define quote unquote established AKI when we're assessing new biomarkers of renal injury, when the definitions have been so dynamic and rely on unreliable surrogates, like you just pointed out, creatinine, cystatin C, urine output? How do we do that?
That is not easy. So again, with the understanding and disclaimer that we don't have tissue to say that there's an established AKI, I think we need to go back to our staging or the criteria. If somebody literally has a change in a creatinine concentration, doubling, 50% increase, just by the use of creatinine, you would say there is an AKI that's happening. Now, whether it's because it's hemodynamic or there's real injury is a different story. But acute kidney injury, in a sense that there's some changes within the kidney tissue, yes, that is established. What is not established is that we take a patient who comes in with a creatinine of 1.0, with a creatinine of 1.0 a month ago. And again, does this patient have AKI or not, the injury or not? And that's where the biomarkers come in. That could be a little bit more useful and sensitive and specific in terms of what the creatinine cannot do. Remember, creatinine changes late. It is influenced by many things, if that answers your question. But if somebody has a doubling of creatinine, yeah, there is established AKI. There's no question about it.
Because let's walk through this. If somebody has a doubling of creatinine, you know that their clearance is 0. Why is it hard to predict who will have a chronically impaired GFR after this AKI injury? Why is that so challenging?
Yeah, that's the challenging. But again, that's at that point, what you're really interested in is if you have somebody with doubling with creatinine and then you add a biomarker, you can actually stratify in terms of, hey, this patient is going to need some additional CRRT or not, or the patient is going to respond to treatment or not. And then we use all the clinical other techniques. We use the urine output, we use the urine microscopy and other things, and put it into context and say, yeah, this patient is likely or not. The problem that we have, as you're pointing out, is that it's so hard to predict. We can't really have a treatment not knowing what's going to happen to a patient. So that's where the additional biomarker needs to come in and tell us, you know what, you're seeing this, but at the same time, NGAL has gone up. Yeah, there is definite problem. There's a need, a CRRT. You can put this patient into a CRRT need pathway. NGAL is low. Hey, maybe the patient needs a lot of fluids. There's a prorenal state. Just give them as aggressive as possible, because somebody with a GFR 0 comes in. You're sort of like, should I give fluids or not? Am I going to put the patient at risk or not? And that's where the difference, can help you out in terms of taking a patient from that doubling of creatinine into the next step.
That's terrific. And I love that example because it actually illustrates how those biomarkers could be useful in a clinical setting. But you talked about a lot of them, NGAL to IL-18, many others. Why have these not made it to practice in terms of our daily practice today?
Yeah, so as I said, the world of developing a biomarker requires a lot of steps. Most importantly, the validation. I think we are a little bit both aggressive, also a little skeptical about what we do. There's a group of individuals that, like Michelle and nephrologists in this audience would know, Dr. Claudio Ronco and others, who says that these should be used, and there's no need for us not to use it. And then there's another group of individuals who say, you know what, we have seen very small incremental value of these, so there's no need to apply. I think the most important thing is we need to take this next step, take some of them, like NGAL. And I think, NephroCheck is really taking a lot of traction right now, and put them into certain parts of your practice and do an implementation study and see if you get this cost-effective strategy. You don't want to take another test and put it out there, not use it, or just spend a lot of money but not know what to do. The reason is, I would say, more than anything, the skepticism of the nephrologist to say, yes, we should do it. I think we would be a little bit more aggressive, much like our cardiology colleagues. Take it and try it.
Take it and try it. Okay, that's good advice. Stu Linus from our division of nephrology has a question for you, Dr. Ikizler. Do you think it's the amount rather than the content of fluid that might be the real determinant of outcome?
In terms of the content issue, I'm not going to go into detail. I was convinced that we should treat people with balanced crystalloids no matter what after the SMART study. Now that I see more and more studies showing that that's not the case, that may not be the issue. In terms of the amount of fluid, yes, I agree. I think we probably don't have an understanding of how to really manage the volume status. We have no tools to understand what the actual volume, extracellular volume, third spacing, everything happens in AKI. That really puts people at risk in terms of really getting into trouble. I do agree that that is a bigger issue, and I think we should pay more attention to that in terms of future studies, trying to see if we can keep people dry versus euvolemic, a little bit hypervolemic, and see if that makes a difference or not. For some reason, we don't study that. I mean, that's like such a low-hanging fruit, but we try to do different things. But I love to see a study where you say, I'm going to be as aggressive in terms of fluid removal. I don't care about the creatinine. I don't care anything about it. I'm just going to, get a really strategy that removes as much fluid as possible versus just let people be, more flexible and see what happens down the road.
Do you have a hypothesis of the outcome there, Dr. Ikizler?
I would say I think we probably let people be too overhydrated. I'd rather be a little bit more aggressive in my management if I were to manage, but
yeah.
Well, 50-50. Not that because I know better than anyone else.
50-50. I love it.
And that's why we need to do a study, isn't that right? It's an opportunity to really.
I get it. I mean, it's related to a question asked by one of our house staff. So this house staff asks, when we pre-treat patients with IV fluids prior to a cardiac cath, how do you suggest we balance sufficient prehydration while avoiding hypervolemia if the patient has cardiac dysfunction? Where's the balance there?
So again, going back to the clinical context, if the patient that you're dealing with, the cardiac cath, comes in with heart failure, what you need to do is not give fluids, but treat the hypervolemia, heart failure. If a patient comes in euvolemic, you can get as much fluid as you want. The kidneys are very responsive. Trust in the kidneys, they'll get rid of it. If anything, the contrast-induced nephropathy is a more risk post-procedure than pre-procedure. What we try to preach is because of the osmotic diuresis that happens with the contrast and potential risk of local injury and oxidative stress with the contrast, you try to hydrate them post-procedure. A lot of times people get into trouble because they go home too quick without really getting a good advice. We tell these people, watch your urine output and drink more than at least a couple of ounces more than what you're doing urine output for the next day or so. And that seems to be more effective. If that's practically speaking, that's where you need to pay attention to.
No, that's great. We're almost at time, but I think we have one question that I want to bring about race, since you touched that on COVID. And the question is, we have recently become more aware of the impact of race-based medicine on patients, both in kidney disease, but also I think when it comes to pulse oximetry, for example, with COVID, also with pulmonary function tests. Can you comment on this in the case of CKD and dialysis with race-based adjustments? This is, relevant in terms of Medicaid eligibility and putting people on dialysis as well. What should we know about this?
You should invite one of my good colleagues who can talk about this for a long time. We can have a symposium if you like. Briefly, what I would say is that we unnecessarily put race as a criteria for diagnostic tools and classification. I think this was initially started with a good intent for the CKD, GFR equations and estimation of the kidney function, but I think it's taken out of context right now. I see no reason in general, no reason to include race into the equations at this point, because race itself, as you all know, I don't need to repeat this, is not a biological thing, it's more of a social construct, and we cannot really adjust for it. What we see as a difference in patients with different ethnic and racial backgrounds needs to be studied further, but we don't need to really use it in the clinical practice to tell a patient you have a GFR of 30 versus 29. It creates an unnecessary bias. That was not the initial intent. As I said, I can speak about this because Vanderbilt is a leader in this concept. We were one of the first to really remove the race equation, made a couple of big things, and our division actually got the award for this because we were pushing it very hard. We've seen that implementation is very hard because people still ask, why are you doing this? But the bottom line is it's not needed. It really is not needed in the clinical context. It doesn't make any impact in terms of managing the patient differently. Just take it out. You know?
No, it's such a powerful statement for many reasons. And I think, you'll be happy to know Dr. Chanchal's leadership, we have followed suit and we have taken it out of our equations here as well.
Yeah, well, I'm sure I can't expect anything less. I'm sure maybe Michelle might have done it earlier than I am, just trying to take some recognition here. But I'm so glad to hear that.
Well, I'll thank you. We're a few minutes over. I appreciate your patience. Thank you for a really wonderful grand rounds and a very illuminating overview of acute kidney injury. We're grateful to have had you with us for this past hour. Thanks very much.
Not be thankful enough. Thank you so much.
Bye-bye.